Experts break rules, and sometimes that's okay. But the experts know which rules they can break and what the consequences are.
Absolutely.
A novice or even a competent person doesn't know that. So you may say, oh, well, she skipped that step, so I'm going to skip it. No, bad idea. Wait until
Yeah.
you're an expert to decide what you can skip and what you can't skip. And we hope that experts who are precepting new people aren't skipping steps.
Yeah.
But as we said, not all experts are good preceptors.
It's
So,
true.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, welcome back to the Art of Emergency Nursing podcast. This is Kevin McFarland. I want to say a big thanks to the listeners who answered my call to go and leave a rating and review. We got a few more rating and reviews than we did last week. If you haven't done so yet, please do so. Please leave us a nice rating and a nice review on iTunes. We'd really appreciate that. That helps other people find the podcast. But more importantly, what you need to do is you need to share this podcast. Share this podcast with your friends, people you like, people you don't like. Everybody needs to hear what we're talking about here on Art of Emergency Nursing. My guest today is a longtime nurse, a clinical nurse specialist, which you'll hear a little bit more about, an educator, an author, and a thought leader in emergency nursing. She's one of the people that when I first met her, I was a little intimidated by her, just by her presence and her name preceded her. But then I found out how wonderful she was, and now I have the opportunity to call her my friend, and I'm honored to have that. My guest today is the one, the only, Jean Proehl.
all right. Well, I'm Jean Proehl. I am an emergency nurse and an emergency clinical nurse specialist. I've been practicing as an emergency nurse since 1981, although I was a tech and an LPN in the emergency department while I was still in my BSN program. I began my practice as an emergency clinical nurse specialist in 1985, and I was a hospital-based CNS for 25 years. The last 9 years, I've been more of a free-range CNS doing a wide variety of things, including working per diem at the stretcher side in a large tertiary care level 1 trauma center and a small critical access hospital. I was president of ENA in 1999, and I've remained active in ENA throughout. Currently, I am a member of the Clinical Practice Guidelines Committee.
You mentioned you work both at a large academic center and a critical access center. What do you think is the biggest difference between the two that's not obvious? I mean, certainly the obvious are things like the availability of resources. Do you see it?
Yes. Well, obviously, you have far more resources in the academic medical center, but sometimes that's to your detriment, and it slows things down terrifically occasionally. And things do get lost when you have that many players involved in a patient's care. So the type of complaints are, of course, very similar because the critical access hospital is a long ways away from a tertiary care center, and that means that patients who have serious illness or injury often arrive on our doorstep for stabilization before we transfer them on. Now, you get a higher proportion of those types of patients at the tertiary care level 1 trauma center because they are referred on. So you see more of the sick patients, but there's virtually no type of patient that you wouldn't see in a critical access hospital that you would see in a tertiary care center. It's just the volume and the frequency.
Yeah. Tell me a little bit. You mentioned that you were a clinical nurse specialist. Tell me what that means for folks who aren't familiar with that term.
A clinical nurse specialist is an advanced practice role. It was actually the very first of the 4 advanced practice roles that are recognized, the others being nurse practitioner, CRNA or nurse anesthetist, and CNM or certified nurse midwife. But clinical nurse specialists, unlike the other 3 branches, really focus on the nurse. I like to say the other 3 take care of patients as their primary population. Clinical nurse specialists take care of nurses as their primary population so that nurses can take care of their patients. And that involves a wide variety of activities. I always said that it merged well with my emergency nurse ADD, because you don't do the same thing all day long.
I got that too.
Yeah. So there's a huge education component, but there's also a clinical expertise practice component. Research is one of the sub roles, but it's not necessarily the traditional research role of going out and doing research. In fact, it's more often digesting research and figuring out how to apply that to practice. There's also a leadership component of that, and it's just a lot of fun because you get to address a variety of things that help nurses at the stretcher side take better care of their patients. It might be getting a policy written, it might be getting a new piece of equipment, it might be monitoring everybody's documentation and helping them improve it. Now, as more of a consultant CNS, I do things sometimes for hospitals, call me in to help look at what they've got in place. I do, as I said, I'm on the Clinical Practice Guidelines Committee, so I'm heavy into the research evaluation and application component there, editing, publishing, etc.
That's awesome. What a cool role to be in, to do some, consultant work and be able to just go in and kind of troubleshoot the things that you're very specifically familiar with.
Right.
What a cool role.
Yeah. And I like to say that people would always say I was their boss. I wasn't ever anybody's boss because I don't do the schedule and I don't do payroll, the two things that you really don't want to screw up or you're going to make them very unhappy.
Boy, talk about getting people angry. Oh,
yeah. But, I would have input if there was a disciplinary action. If there was a component of clinical practice in that, I obviously would be involved. If it's, not showing up for work, calling in sick, inappropriate interactions with other people, unless I had been directly involved in the situation, that would not be something I would ever deal with. So,
gotcha. That sounds like a pretty okay role.
yeah, I have loved it.
I bet. Now, when you say you work at the large academic center and then the critical access center, are you in the CNS role or are you more in a staff role?
Well, at the critical access hospital, I am an emergency department per diem nurse, but they often use me to teach classes,
of course,
help, run policies by me, etc., to get input on how we could change things. At the academic medical center, I again work as a stretcher side per diem nurse. I also work as a per diem in the education department, working on advanced cardiac life support, moderate sedation, those sorts of things.
Nice.
So it's a nice variety.
What have you found in your education role? What have you found the most rewarding thing about being an educator?
Helping people get to that aha moment of, oh, I get it. Maybe something they've had explained to them before and just didn't quite make sense to them. Or maybe they've never heard it before, but it's kind of a difficult concept, or it opens up a line of thinking that they hadn't considered. That's absolutely the best. And then seeing people take that knowledge and confidence to the bedside to help deliver the best possible patient care.
That's pretty cool. That's a pretty cool thing to see, I'm sure.
Yeah.
So what made you decide to get into nursing? Why nursing in the first place?
That's a really good question. And I can't exactly answer it other than to say, I remember watching Captain Kangaroo many, many years ago, and him talking about what are you going to be when you grow up? And just deciding I was going to be a nurse. Now, at that point, I'm not sure I'd had much exposure to nurses because
Interesting.
There were no nurses in my family. My family are all school teachers. I guess that explains how I got pulled into the education side of it. But
yeah,
it sounds corny, but I always tell people, I think this really is a calling. And if you're in it for money, you're in it for the wrong reason.
Yeah, I mean, the money, and luckily for us, that the money is good in nursing, but it's not enough to not, if this isn't your calling, if this isn't what you're meant to do in your heart of hearts, you're not gonna. It's not enough. The money's not enough.
Well, exactly. And I find it kind of hysterical actually to say that the money's good, because 40 years ago, of course, when I started, it wasn't. And we would laugh about, oh yeah, I got into this for the money, because nobody would have ever have gone into nursing for the money. And so it's been a good thing that we've been able to elevate salaries to a more commensurate level with our skills and knowledge. But it's a sad thing that people now go into this for the money.
For the money?
Yeah.
How much did you get paid at your first nursing job? Do you remember?
It was just about $10 an hour. And that
Holy
was,
smokes.
that was 3 times what I had been making as an LPN. So I was rich. We could afford to go out to eat sometimes, and it was amazing.
You're like, wow, we are living high on the hog today.
Yeah. After being a poor student for all those years, it made a huge difference.
I bet. Holy cow. It's crazy. I remember my very first nursing job I started at double what you made. I started at like 21. I remember it was like $20.21 or something.
Wow.
And I was like, and I remember thinking to myself, that I was like, wow, that's it. And I had the opposite work, because at the time as a tech, I was making pretty good money as a tech. I was completely overpaid as a tech. And I was working at the community college, and the community college had just one rate for all instructors, whether you had an ADN or if you had an associate's degree, or if you had a PhD, there was one pay rate, period. So it was a pretty good pay rate. And, so I went there and I was like going, gosh, I'm going to take a pay cut going into nursing. This is crazy. I never thought this would happen.
Yeah, it's amazing how the cycle turns here.
Yeah, and now I look at it and I think to myself, again, still the best choice I could have ever made was becoming a nurse. And I agree with you 100% that I think it's a calling.
Yeah. And, there are so many ways that nursing can take you. People just can't even imagine where you can go with a nursing background, because we have skill, knowledge, and a way of looking at the world that serves you well in a variety of situations.
I agree with that 100%. I think that when I was considering nursing, I actually interviewed to be in a paramedic course, and you had to interview. The paramedic course was very competitive to get into. And I remember interviewing in the paramedic course, and he said, what's your long-term goal? And I said, I think ultimately maybe I want to be a nurse. I think I want to be a flight nurse. And he's like, okay, that's cool. He's like, so if you want to be a nurse, why don't you just go be a nurse? Like, why are you going to paramedic school? And I was like, well, I don't know.
Good.
I figured I'd work as a paramedic, and until I was ready to go to nursing school. And he's like, and this guy was both a paramedic and a nurse, and just still to this day one of the guys who's probably had more influence in my nursing practice than he realizes. He told me, he said, Kevin, I'll give you the advice that I would give my son. He's like, I've been a paramedic and I've been a nurse. And he's like, I'll tell you that you have a lot more options and as a nurse than you ever will as a paramedic. He goes, as a paramedic, you go into, once you're tired of being on the streets, you either go into education, you go into leadership, or you leave the career altogether. He goes, you already do education, you're already doing leadership, so where are you going to go?
Yeah, great advice.
And I was like, that's pretty good advice. And he goes, as a nurse, he goes, if I get tired of teaching, I can go work in the ER. I can go work in an urgent care. I can go work as a trauma coordinator. I can, if I want an 8 to 5 Monday through Friday job, I can do that. If I want to work 3 nights a week, I can do that. He's like, you have lots of options as a nurse. And I was like, whoa, that makes a lot of sense.
Yep, indeed.
So I was like, oh, yeah, okay. Maybe that's the way to go. So and he really kind of pushed me into okay, if you want to be a nurse, go be a nurse.
So did you skip the paramedic thing altogether then?
I did. I skipped the paramedic thing altogether. I still carry my EMT license. I won't let it go because I worked too hard for it. So I'm a EMT intermediate, or what they now call EMT advanced.
Yep.
Through the state of New Mexico, and I haven't carried it over to Texas yet, but I don't know if I'll let it go. Like, I worked too hard for it, and it was a big part of who I was for a long time.
Yeah, I went to an EMT program when I was in college, I never practiced on an ambulance, but I did use that credential to get a technician job in the emergency department when I was still in nursing school.
That's what I did too. It's
Yep.
exactly what I did.
Yeah.
And you want to hear kind of a funny story, just as a side note. So when I taught EMT Basic, I taught EMT Basic for years. I taught EMT Basic, Intermediate, and even taught some of the paramedic courses as a nurse. And my very first EMT Basic course, we had a childbirth video that we used to play every semester for kind of the childbirth lecture. And it was you in the back of an ambulance talking about childbirth.
Oh, geez. Oh, my gosh. I remember that. That was a long time ago. I was actually pregnant when I shot that, but pretty early on. So that
you looked, I might have guessed that, but
yeah, I remember trying to like angle myself so that my belly wasn't like front and center. But yeah, that was shot in Lafayette, Colorado. Of all things.
Kidding.
Yeah.
No kidding. Holy cow. It's, and it was a video that I probably still have that video. It's probably sitting in my bookshelf right now. Because I played that video every single semester when I taught, even, when, some of the information had changed, some of the things had changed about it. It was always like, let's start here.
It's funny. I think you're only like the second person who's ever told me they saw that video. Somebody recognized me in the trauma bay in Florida. I remember one of them saying, "You were in our video about childbirth." It's like,
that's
really?
Funny.
Yeah.
So when I first met you, I don't know, you probably don't remember the first time we met, but the first time we met was at the SESS conference. And I remember, of course, I'm sitting there going, okay, this is Jean Proehl. She's like a legend. She literally wrote the book on emergency nursing. And I remember just being like, all like, well, guess who's here? And so, impressed by that. And I remembered the name as soon as I got into emergency nursing and realized that, you were more than just the lady in the video. You'd done some stuff. So
that's pretty funny.
So I remember being like super impressed when I got to meet you and just thinking that was just the coolest thing. I think I called my wife and told her that night. I was like, guess who I just met? And she's like, I have no idea who that is.
Yeah, very narrow scope of fame there.
Yeah, I was here I was like super impressed, and I told my wife, I'm like, guess who I just met? And she's like, she sounds lovely, but I just don't know. And then of course I told my people at work, and they're like, hey, that's kind of cool. And I'm like, I know, right? So.
Oh, well, thank you. It's nice to know that you made a difference.
You did. I mean, it still, I probably popped that video in. It's still probably pretty good. So.
Well, yeah, but that childbirth thing, man, we've totally revamped how we do the neonatal recess part anyway from those days.
Yeah. I probably would want to skip that part. But, yeah, that's probably a little different.
Babies still do pretty much come out the same way, however.
They do, and by and large, much without our, a whole lot of our help. We just kind of guide the practice and then take the credit.
Exactly. Otherwise, the human race would not exist as we know it.
That's right. Like, people have been doing this for years. It's okay.
Yep.
It's not all about you. Calm down. So, at what point in your career were you sure that you made the right call, that you did go into the right calling?
I don't know if I ever doubted it. I mean, certainly we've all had jobs where we were miserable and couldn't wait to get out of them, but I never thought I wanted to get out of nursing or even emergency nursing. It was just always, this is a bad situation and I can't stay here. So I think it was sort of like from the get-go, I just knew this is where I belonged. It goes along with that calling thing, I guess.
Yeah. Now, did you start in the ER?
Well, I tried to. It
wasn't really a thing then, was it?
No, it wasn't. And as I said, I had been a tech and an LPN and in the emergency department for 2 years before I graduated. But they weren't hiring new grads in the emergency department in those days. And, I really fought against that but unsuccessfully. I had to do a year on inpatient orthopedics. And I have to say, that was really a valuable year. And I think that even though that seems painful and people don't want to do it, I hate to see that we have abandoned that. And I realize that it's necessity in many cases, but you really need to get your nursing feet under you first before you step into an environment as chaotic as the emergency department can be, and where, split-second decisions are life and death, and there may not be anybody else there to make that decision with you. So I went to the emergency department almost exactly a year after I graduated from nursing school, and I've never been anywhere else since then.
That's funny. I started in the emergency department and for the good or the bad, I mean, one of the things I found now in my career we're sitting on more inpatient nurses more inpatient patients than anyone. I'm not good at that.
No, me either.
I'm not good at taking care of an inpatient patient in the emergency department. I remember going, MAR? What do you mean MAR? What does that mean? Holy cow. I don't even know what you're talking about. But I'd never had that experience.
Well, and like I like to say, that this is a big dissatisfier for emergency nurses who we cannot afford to lose. We need all of the emergency nurses we can get. But if we wanted to take care of inpatients, we could. I mean, we could all go find jobs on inpatient units. We don't want to do that. And when you don't want to do something, it usually means you're not necessarily that good at it, and you're not inclined to get better at it.
You're absolutely right. Absolutely right.
And it goes double for the psychiatric boarders, who I feel are being managed unethically. I mean, what worse place could there be for a person in the midst of a mental health crisis than the emergency department?
Oh, there's not many worse places to be.
Yeah, days, weeks, months. We've had people in emergency departments waiting for psychiatric beds for up to 6 months in the area where I live. So you're not doing those people any favors. You're not treating them therapeutically. You're just warehousing them basically, and it's wrong.
Yeah. We had a patient in the hospital where I was working as a house supervisor. We had a patient who was in the emergency department for like 8 days. And we were like, what do you do with a patient who's in the emergency department for 8 days? Mm-hmm. Like, what do you do with that? And
I'm not kidding when I say we have had patients in one of the local emergency departments where my friend is the nurse manager. They had one patient for 4 months and one patient for 6.
What do you do with a patient? Like that's I can't even imagine that.
Well, you just warehouse them. I mean, they're basically just trying to manage their behavior and find a place for them to go. Both of them were geriatric psych patients who were hard to manage. They were violent on occasion. And they came from an inpatient facility that wouldn't take them back.
Yep. Yeah.
So.
Wow. That's crazy. It's crazy to imagine somebody that long. Like.
Yep.
Oh, it's crazy. So. Tell me about a patient who changed the way you practice.
Well, let's see. There have been, I would have to say that probably many of the patients who changed my practice would involve something where a mistake was made, either by me or someone else. So you learn to not ignore the rules or to check something more carefully. Patients who look rather benign and deteriorate quickly have been some of the biggest influences on my practice, like little kids with a rash and fever. Now, remember, when I started in the emergency department 40 years ago, we didn't have Hib vaccine. So a rash and fever often meant meningitis, and those kids could walk in eating a candy bar and be dead in a few hours.
That's crazy.
Yeah, and it was very scary. And I had little kids, during this era. My daughter was actually 5 months old when the Hib vaccine came out, and I couldn't get her to the pediatrician's office fast enough. But, there's other patients that we see, obviously, who come in looking sort of okay and then spiral. So those are the ones who've made me examine things more closely and not poo-poo things that, oh, that's just a red herring. No, maybe you really do need to consider that their heart rate is 120. Maybe there's something to that besides anxiety and pain. So, and then the patients who could have survived or survived with less disability if they had only used basic injury prevention strategies like wearing safety belts and helmets. And I used to think, oh, you don't want to make them feel bad or make their parents feel bad by talking about this stuff while they're in the emergency department. But no, you really need to take advantage of your position of, quote, authority and say to parents, he needs to be wearing a bicycle helmet. That's important. Or seat belts are for everybody. That's important. So I've changed my approach to not being quite so, concerned about how they're going to feel. A little guilt might be good if it helps you implement injury prevention strategies that will save your life or decrease your morbidity.
I mean, what a important place to potentially touch them, and other than in the emergency department. We're like, hey, you're only here because you got real lucky.
Yeah. I remember having a kid one time who had been in a bike crash and his helmet was actually dented on the side. So he had a really significant impact. And he was concussed, but he never, lost consciousness. His vital signs were fine. And his mom came in after, he arrived by ambulance. So his mom arrived a little bit later. And I said to her, how lucky or how great it is that he had his helmet on, and it probably saved his life. If not, it prevented a very serious head injury. Look at this helmet. And she said, he doesn't have a bicycle helmet. That's not his helmet. I don't know where that came from. So in further follow-up, he was with a friend, and the friend's father would not let them ride bikes unless they both had helmets on. So I said to the mom, you need to go out there and thank him, and now go home and buy helmets for the rest of your kids.
Right? Go and buy helmets.
Yep.
Or, in so many ERs, they're just like, here, take one.
Yeah. Yep, exactly.
So, because it's that important.
Yep.
So,
if you can only do two things, safety belts and helmets. I know you can't necessarily pay attention to every little silly thing, like plugging outlet covers turns out not to be necessarily that big of a deal because not that many kids stick things in outlets, but helmets and safety belts.
Yeah, those are two big ones, aren't they?
Yep.
So, tell me about the first time you made a medication error. Do you remember it?
Oh, I remember it dramatically. And there's a whole bunch of things that you can take from this. I walked in, it was pretty busy. I had not received report and things were sort of going crazy. And one of my friends walked up to me and said, can you do me a favor? Can you go give this Compazine to that crocky lady over there? Now, crock being, a derogatory term for somebody who we think is just making up everything. And what I didn't realize were that there were two of those patients who sort of fit that description. And so I just went in and...
There's always at least two.
Yeah, I just went in and gave it to the one I was familiar with who was not the right person. So I never obviously looked at the order or identified the patient in a way that was appropriate, and ended up giving her 10 of Compazine, which didn't hurt her, fortunately. But I do remember feeling like, oh my God, I can't believe I just did that. I had gotten so comfortable in the environment that I thought, yeah, I can just go do that. So now, many years later, I had a similar situation where I walked into a different ED and it was crazy and I was the CNS there. And I said to the charge nurse, listen, I got about 15 minutes. What can I help you with before I have to be somewhere else? And she said, here, go give this Haldol to that crazy guy over there. And I turned around and said,
stand by.
You're going to have to be more specific. So I did verify that one. I learned my lesson.
That's funny. What an important lesson to learn.
Yeah.
Hey, you know what?
Well, and I violated basic nursing practice. And I violated it because I felt so comfortable that I could just, oh yeah, I can go do that.
How often do you think it is that comfort is exactly what gets us in trouble?
Oh, I think it's pretty often.
You mentioned comfort, and I just thought to myself, I don't know how many times I've been too comfortable with whatever I'm doing, whoever I was with, whatever was going on, that I just wasn't paying attention. I wasn't my most diligent self.
Yeah, I think we could equate that with arrogance. And,
Yeah, for sure.
get somebody who knows it all or thinks they know it all. And we've been there. I mean, it would be, I think, maybe the uncommon person in emergency nursing who would say they've never been overconfident and found out later that they were inappropriately confident.
It happens all the time. It happens all the time.
Yep. We just hope people learn from it.
Yeah, learn from it and the have the wherewithal to just maintain presence and be like, okay, yeah, which crocky patient is this that
Or which
that's
crazy
going to get the
patient.
meds?
Yes.
Yeah, who's going to get this?
Yep.
Which of these psych patients do you mean? And it's easy to have happen. It's easy to just kind of just whiz through things and be like, okay, yeah, let's get it done.
Yeah. Well,
Okay.
and that doesn't even, take into account that we shouldn't be labeling people in that fashion. But I think that's something we all eventually recognize as not an appropriate habit. But in the early days, and certainly 40 years ago, it was much more common.
Yeah, for sure. So, tell me about a patient who touched your heart. Someone that you'll never forget.
Oh, wow. There have been a lot of those. Probably one of the more recent ones I remember was a woman she's younger than me by about 10 years probably, and she's got breast cancer. She had breast cancer. She has since passed away. She was in the emergency department for something that really wasn't a big deal, and I don't remember what it was, but she knew she was going to die, and her prognosis was weeks, not years. And I remember her daughter coming in. She had not been home when her mother was taken to the emergency department for whatever reason. And of course, the daughter comes in thinking that this is going to be the end, and she's not ready for it. And I remember the mother trying to console the daughter and comfort her, no, it's not the end now, but the end. And I remember the mom making eye contact with me and just looking at her like, what an awful place to be. First of all, you're going to die. But what's worse than that is look at what it's doing to your kids.
Yeah.
There's nothing you can do about it.
Holy cow. That's a tough one.
Yeah.
How many times? I mean, if you think about how many times we've been around, sometimes I'm amazed to think of how many people we've seen either, just before their death or even people you've watched take their last breath.
Yep.
And it's incredibly daunting to think of that as an emergency nurse, to think about all those people that you've seen first breaths and you've seen last.
Yeah, and I think, people always say, how do you deal with it? And I think, of course, it's not every day, every shift that we have patients die or who are dying, even in most cases. But we also don't generally have a long-term relationship with our patients. And so we don't know them. And for better or worse, that makes it easier not to take all of those quite so to the core. But
take all those ghosts home.
Yeah, exactly.
Yeah. I remember when I was doing my BSN, I had to do some community clinicals, and I did my community clinicals in a pediatric hospice.
Oh,
and that's what I said.
Oh, man.
That's what I said. I was like, holy cow. So they suggested like hospice or home health, and the one that I had easiest access to, all they did was peds. So I was like, okay, well, I've been a peds nurse before. I could do this. Won't be easy, but I can do this. So I remember going there for the first day and meeting with the director, and the director's like, what do you expect to see? She's like, do you expect to just come in and see a bunch of kids die while you're here? And I'm like, God, I hope not. I was like, please, no, I'm not ready for that crap.
Right.
And she's like, I don't think that's what you're going to see. I don't think that's what you're going to see here. And I'm like, well, I hope not. I guess certainly that's not what I'm expecting and not what I'm anticipating. I go, I'm hoping that I'll see good care. I'm hoping that I'll see, nurses doing the best they can for the family and for the patients and their families. And I hope I see reason for hope. And she was like, that's a great answer. So,
Good.
and it was. I mean, in my pediatric hospice rotation, I didn't have any of the children that I was there for die.
Wow.
And actually, one graduated from hospice. One, when we went there and we were talking to her, and they're like, "She looks so good, we're gonna take her off hospice." And we're like, "Wow!" I'm like, I didn't expect to see that either.
I didn't know that ever happened.
It happens, yeah. So the nurse I was working with, and bless her soul, she's an angel. She's probably one of the toughest women I can even imagine. She had a pin board of many of the children who've come and gone through their service, but she had a much smaller pin board. But she said, these, and she had like a little cap and gown on that pin board. And she said, this is my graduated from hospice. We put you in hospice and you did better. So,
Wow.
and of course it was a much smaller pin board, but it was still hopeful. And it was still cool to see that she had that kind of hope.
Right.
So,
Yeah, see, I would think that would be far more difficult than what we do.
Right. And, you sit there and think to yourself, I thought to myself, I'm like, I'd been, I'd been an ER nurse for a long time and been in the ER as a tech as well, for a long time when I went there. And I remember thinking to myself, oh, I got this. This is going to be, you're not, I'm pretty tough, but no, nothing compared to these guys. So.
It's a good thing that people are attracted to different things, because we wouldn't want a world full of emergency nurses.
Right. That's just not the right mix.
Right. There's someone for everything and something for everyone.
What do you think makes emergency nurses unique?
Well, you have to thrive a little bit on chaos, but the bottom line is all of us are a little bit of control freaks. So that's why we like the chaos, because we like to get it under control. Yeah. And I think that short attention span, I'm not kidding. I really think that's professional ADD. I don't want to look at the same patient for 12 hours. I just don't, or even 8.
Yeah. Yeah. You're like, I'm not into long-term relationships. You got to go.
Right. And I'm not happy just knowing about, and I think this applies to all emergency nurses, I'm not happy just knowing about your heart. As I used to say to my friend who was the cardiac CNS, it's just one organ. They have lots more organs.
Like, it's just a piece of the puzzle.
Right. So I like knowing a little bit about a lot of stuff. And I guess I wouldn't say that we know a little bit. We know a key subset of the information about a lot of different things.
It's a good way to put it.
Yeah.
It's a good way to put it, because you always think you know a little bit about a lot, but we know key information about
we
many
can
things.
Save you to get you to the people who know a lot about what you've
That's
got.
right.
But
that's right.
It's if you think about it, there is nobody who doesn't come through our door at some point. Every age, every acuity, every possible injury or illness. Yeah. They're all showing up sooner or later in an emergency department near you. So the possibilities are endless. And then it helps you appreciate that garden variety otitis media in a 3-year-old that you just get to coach mom in how to give oral meds to and send on their merry way, even though you've seen 10,000 of them. You appreciate them because not all of your patients are that easy.
No, they're not all that easy for sure. Tell me about a patient that you'll never forget.
Well, one of my favorites was a guy where I almost made the mistake of categorizing him as man flu. He was a 32-year-old guy who came in at 4 a.m. His wife drove him in, and he looks pretty much fine, really. And he's doing that. Oh, I've got diarrhea. And I'm thinking, oh, geez, you got diarrhea, Okay, come on.
Hey.
So, yeah.
I'm pretty, Jane, speaking for all men, I'm pretty sure it's worse in men than women. I'm pretty sure it has to be because it seems to affect me way worse than my wife.
Yeah, that's probably it. So anyway, it was the middle of the night. So typically we would bring patients back to the room to triage them, although we could get vital signs and stuff in triage if we wanted to. But if we had an open bed, we just brought him back. So he was walking, and I said, okay, well, let's go back and we'll get your blood pressure and everything. And I grabbed his arm, trying to quote, help him. And I was actually just trying to hustle him along. And he was like, ouch, 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 ouch. Oh, I've got a spider bite. And I'm now, doing the eye roll. Yeah, he's got a spider bite. Okay, yeah. So I get him back, and I put him on a stretcher, and I can't feel a radial pulse. And I feel the other, and he's still talking to me, and I feel the other arm, and I can't feel one there either. Now, I do want to say that that's a myth, that if you can feel a pulse at the radius, that their blood pressure is at least 90. That overestimates blood pressure, and we know that. But I did know it is bad if you can't feel it because their blood pressure is so low. So I laid him down and put him on it was a Dynamap. This was many years ago. And it just kept alarming low, low, low. So now I think maybe I should go get the doctor. And I said to the doctor who stands at the desk, that guy just walked by? Yeah. I can't feel a radial pulse. He's like, what? I said, I think you need to come in and see him. So short story long, he had myocarditis from his spider bite.
Holy cow.
And he damn near died. We put, I think I got a 14 gauge in his right intern's vein. I mean, I can still remember where I was standing and everything.
Oorah.
And poured in 2 liters of fluid, and his blood pressure, he still doesn't have a decent blood pressure. And it was a family practice resident who was working the ED that night. And I said, you got to put a central line in. He's like, well. And I remember he had this roll of Lifesaver mints that he kept in his pocket, and he is popping mints in his mouth like crazy. I said, no, you got to do this. Well, he needs an echo. I said, it's going to take echo a while to get in here.
Yeah, that's not happening tonight.
Well, it happened about 6 o'clock, so a couple hours later. But when we put the CVP in, old days, we had a manometer, and it popped out the top. And, you think, oh, geez, I turned the stopcock the wrong way. So you do it again, and it pops out the top, and you're like, come on, pay attention, you're screwing this up. And then the third time, it's like, you know what? I don't think this is me. I think this is him. And sure enough, we'd just given him 2 extra liters of fluid that his heart couldn't pump around, which was, whoa. And so then, echo comes in, and he's got a hypokinetic heart, the whole 9 yards. And we sort of debriefed a little bit, but it was towards the end of the shift. So I went home and went to bed and sort of forgot about it. I came back to work the next night, and at 11 o'clock, the CCU nurses called and said, the patient that you took care of last night would like to see you. And I'm thinking, oh no. What? I thought I did really well with it. I don't think he saw me roll my eyes when he said spider bite. He had a box of chocolates for me. And I was astonished. My jaw just dropped. And he said, I am a healthcare professional. I won't specify what type, but it was clear to me that you were the only one in the room last night who really knew what was going on. And I thought, if you only knew Mr. Man Flu Spider Bite. But, I learned a lot from that. And now I may still classify you as man flu, but I'm going to get a lot more information before I do.
We're going to trust but verify.
That's right.
We're going to go through some stuff first.
Yeah, that's right. And, to this day, that's the only patient. And it's not that you do this for the box of chocolates, but when you work on an inpatient unit, people bring you chocolates and snacks and all that kind of stuff. That doesn't happen. It doesn't happen in the ER. Mm-mm.
We don't build those long-term relationships where they love us for a little while, but then they forget about us.
Well, right. Or they don't even remember us many times, I'm sure. And that's probably a good thing. But that was pretty memorable. I actually still have a copy of his chart.
Holy cow, that's cool. What a cool catch of, wait, hold on. You don't have a pulse, my friend.
Yeah. Well, and there's no way that I wasn't still attaching the spider bite to the myocarditis. I just knew that he was in cardiogenic shock. That's all I knew. And I didn't know why, but I knew that we couldn't keep giving him ringers because we weren't
Yeah,
helping
you're
things.
like, we're not helping.
Yeah.
Putting a lot of fluid in that tank. That's
Yep.
not working real well.
Yep.
That's interesting. What's the best advice a nurse mentor ever gave you?
Well, I've had several mentors, and I think rather than just one specific piece of advice, what they've done that's made a huge difference in my career is they have pushed me toward doing things that I might have chosen not to do, but they were like, no, you got this. You can do this. I'm sure you can do it. And that's how I got started with a lot of my teaching. It's how I got started with the first edition of my book. That was actually Peggy McMahon gave my name to a publisher, and
No kidding.
yeah, the rest is history. So believing in yourself and taking those opportunities when they present themselves.
How cool is that? I'm actually sitting here looking at Peggy McMahon's card.
Oh,
She is one of the people on my list that I really want to interview.
oh man, she's got some cool stuff. She did 2 tours in Vietnam.
I did not know that.
Yes, she did 2 tours in Vietnam, and she came home and they got a grant and did education for emergency nurses all over Washington state, every little rural hospital, everybody.
That's amazing.
And ask her about the generic air freshener.
Generic air freshener.
Yeah, she's got a great story. It'll teach you the importance of labeling if you didn't already know that.
You're probably more so than a lot of the people I interview in an opportunity that you get to mentor a lot of people. What are your go-to mentoring lessons to, you're kind of generic. I know we all have, specific stuff once we kind of get to know them a little bit, but what are your kind of generic go-to, hey, let me give you some advice?
Well, I've actually been like a formal mentor through the academy several times, and people usually come into that with a project in mind. So typically people come to me with a specific issue or question that they want to address, and helping them figure out what the real question is and how to find the evidence to find the answer. I'm huge on looking for evidence and not just the way we've always done it. And taking advantage of those opportunities, just like my mentors did for me. When an opportunity comes along, you got to grab it because it may not come again. And you're going to have to decide work-life balance, how many of those opportunities you're going to grab. But if you don't grab them, you got to realize that it may never come again.
Absolutely. What advice would you give a brand new emergency nurse?
Well, I would tell them to watch everybody, observe their practice, nurses and physicians, read their notes, and especially when they identify the experts, try to get inside their reasoning process, because we know experts are not always the best preceptors. They tend to skip steps. They tend to know things without verbalizing why they know it. And some of them can put the brakes on that and explain to a new nurse that they're precepting why they did this or why they didn't do this. But
those are two different skill sets.
Absolutely. But, I used to work with a physician many years ago who was a brilliant diagnostician, but he was also a jerk. And he would walk into the room and he'd just know what was going on. But you could never ask him because he always took it as an affront. Like, how did you know that guy had hepatitis? Or how did you know, so of course, those are toxic people that you want to avoid. And hopefully we see less of that behavior now than previously. But, after the dust has settled, you were right on top of that. I remember one time, not all that long ago, a guy came in who was using injectable drugs, and I don't know what was in his drug, but he had flash pulmonary edema. And he came in diaphoretic blue and cold, barely breathing. And the nurse, I scooped him up from triage. The nurse in the back ran with me, and I got one of the ED physicians. And he's like, we're trying to give him a neb. You can't give him a neb because he's not moving enough air. And the physician looked at me and said, 0.3 of epi now. I ran and got the epi, gave it to him. He turned around, we got him calmed down, everything. The other nurse came to me and said, so you think that was an allergic reaction? I said, no. Let's talk about what epi does. We couldn't get the drugs into his airways because he was too clamped down. We had to open up his airways so we could get the drugs in to stop the bronchospasm. So she didn't question it at the time. She just went with what was happening. But then later she followed it up. She didn't just assume, it must have been an allergic reaction they were thinking of. So that's important. And maintaining the moral high ground. I can't emphasize that enough. Nursing has been at the top of the public's trust list for probably almost 20 years now. I think the only year we weren't, since they put us in the Gallup poll, was 9/11, the year of 9/11 when firefighters got the top. And if you don't maintain that, it's going to be really hard to get back. So I like the definition of integrity of it's doing what you do when nobody's looking. You do the right thing, even though nobody's looking. And we have to be there for our patients. And if the patients trust us, that's going to make all the difference in the world. And there was actually another poll that just came out that said the public, in terms of reforming or reorganizing healthcare, the public felt nurses had the most trustworthy voice in that. I hope the policymakers are listening and that nurses are at those tables.
Absolutely. Having nursing have a seat at those tables is just critical because we're the ones who are there at the patient bedside and taking care of those patients and oftentimes know more of what's going on than the physicians that we support.
Absolutely. And all of these conflict of interest things that have come about in recent years, I get kind of annoyed that we have to fill out all these papers at work when everybody knows it wasn't the nurses who were getting that stuff anyway. It was the physicians. Big Pharma is not coming to the ED and taking me out golfing or anything. It's just, yeah. So, and the other thing about experts is, in addition to trying to get to what they're thinking and how they knew it, don't mimic their behavior when it violates principles that you've learned. Experts break rules, and sometimes that's okay, but the experts know which rules they can break and what the consequences are. A novice or even a competent person doesn't know that. So you may say, oh, well, she skipped that step, so I'm going to skip it. No, bad idea. Wait until you're an expert to decide what you can skip and what you can't skip. And we hope that experts who are precepting new people aren't skipping steps.
Yeah.
But as we said, not all experts are good preceptors.
It's true. That's true. Yeah, I remember we had some very, very skilled clinical providers that were fantastic nurses, but they just weren't good preceptors. And the better preceptor for people a lot of times was somebody who knew it pretty well, but worked really hard at it. And because they worked really hard at it, they could explain it. And they could explain it really well because they weren't 100% confident in their knowledge themselves.
Yep.
But they'd be fantastic preceptors.
Yeah, I think people who have like 3 to 4 years of experience are often prime candidates to be preceptors because they've learned a lot and they're beginning to be able to see what's salient and what's not, but they haven't abandoned following all the rules and they still remember what it was like not to know what they know or what an expert knows.
Absolutely. That's like the sweet spot for preceptors, I think.
Right. Well, and of course, experts do sloppy things too that
Yeah.
that are wrong, like my pet peeve, and it's been my pet peeve for 40 years, since way before all of the recent attention to it, but labeling unlabeled specimens, setting them on the desk. No, the blood specimen never leaves the patient's bedside until it's labeled. And I probably came by that because I worked in a lab as a phlebotomist early on. But just last night at work, we've got a relatively new nurse, and out she walks with the specimens in a emesis basin. I'm like, where are the labels? Well, I got to go get them. I said, the blood never leaves the patient's side until it's labeled. Go hand it to the patient while you go get the labels. And next time, grab the labels before you go in the room. And I said, and she sort of looked at me like, well, nobody else does it that way. And I said, you're going to see people break that rule. And let me just tell you, it could be a life-threatening rule to break.
Absolutely.
So.
Absolutely it can. Do you find, and this is just a question for you, do you find people, like, I can't imagine showing up to a shift and working side by side with you and being like, wow, I shouldn't even be holding her water.
Oh, no. I have to go get people to start IVs because some days I'm just not on when it comes to that. I get a lot of help with the computer because I work in 2 different places with 2 different charting systems and screw that up on a pretty regular basis. I think that people who work with me, who have really truly worked with me close side by side, would say, oh yeah, she doesn't know it all. She knows a lot, but she doesn't know it all.
That's good to hear. That's good to hear. So the last question I always ask my guests is a question called 3 things. And the question is, what are 3 things an ER nurse should always remember? And what are 3 things they just need to forget? They just need to get out of their head.
Okay, well, the first one is something we've just been talking about. The rules are there for a reason. Break them at your patient's peril. So you're supposed to do something. There better be a really good reason why you don't do it that way.
Yeah.
The second would be ask why. When things don't make sense, don't just shrug it off and go on your way. Find out why something doesn't make sense. Put the pieces together. You can't lose that curiosity. And don't forget that saving lives is a team effort, and nursing is an essential part of the team. You should never think that you don't have much skin because you're just the nurse. Don't ever think that.
Absolutely. And 3 things to forget?
Well, following up on that last thing to remember, forget that captain of the ship dogma. The physician knows a lot. They know more than you about some things, but they don't know everything. You need to own your patients. And don't just do something because the physician or whatever provider you're working with tells you to do. I would also forget all those myths. For some reason, myths tend to stick in people's heads better than other things, like the myth that oxygen can't hurt you, or the myth that I mentioned earlier that you've got a blood pressure greater than 90 if you can feel a radial pulse. You need to go look at the evidence and see what the research shows. There's also the myth that you can't use oxygen with patients who have COPD. Not true.
Yeah.
And then forget thinking you will ever have seen it all and know it all, because you're dangerous when you think that. And the next time you have the nerve to say, I've seen it all, you can bet that the very next patient through the door is going to prove you wrong.
Absolutely.
And I might just add one of my other little pet peeves. Forget thinking that 12-hour shifts are wonderful. 12-hour shifts are associated with an increase in errors. We know this. And yet we deny this data because it's not what we want to hear, and nurses want to work 312 so that they can have 4 days off, or so that they can go work another full-time job. And it's dangerous. We know that. And I think that one day the regulatory agencies are going to step in and say, no, 10-hour shifts are the maximum, except in exceptional cases. But routinely, 12-hour shifts are not a good idea. And the younger nurses are going to all argue with me about this, I know. But I'm telling you, the data's out there. And as you get older and recognize better your own acuity, your own faculties sort of waning after 8 hours, you come to appreciate that maybe this isn't in the best interest of our patients.
I have a tough time with this one because I'm a big fan of the 12-hour shifts, but that's because I'm a big fan of 3-4 days off.
Right.
But you're absolutely right. I think that you're much more likely to make a mistake. The data shows you're much more likely to make a mistake in hours 9 through 12 than you are in 1 through 8. Right.
And why are we okay with that? I actually brought this up at the American Academy of Nursing last year. We were given an opportunity to submit questions to a distinguished panel. Bernice Melnick was the moderator of the panel. And so we passed in our cards, and you think, and you're in a room of 700 people, they're never going to get to my question. And that was the one she actually picked out. And she said, I have a personal interest in this. This is one of my frustrations as well. We have the data. Why don't we do this? And everybody in the room said, well, all of our nurses will quit. And I piped up from the back, not if you all do it.
It's true.
If one hospital does it, yes, maybe you're going to have some nurses heading in. But if every hospital does it, then it levels the playing field. And I think it's in the best interest of patients. I think it's in the best interest of nurses, too, because if you want the experienced, seasoned nurses to hang around, we don't want to do 12-hour shifts. I do them occasionally, but I don't want to do 12s. I'm old.
I love to go in and do like a little princess shift, every now and then.
Yeah.
I've been doing all last week. I was working at the pediatric hospital and I was doing 8-hour shifts, and I was like, this is really nice to go home. Of course I was going home at 3:00 in the morning. That's suboptimal. But I was like, hey, I can go home and be in bed before sunup.
Yeah. Well, and it's amazing how much I dread going for a 12-hour shift. But yet, if I'm going for 4 or 6 or even 8, I think I can put up with anything for 4 to 6 hours. And furthermore, I can't go for 12 hours without sitting, eating, drinking, or peeing anymore. And sometimes in 12 hours, you don't get to do those 4 things.
Yeah, those are certainly things that are to be done when you have the opportunity.
Yes. So if you're really buying into the life-work balance and taking care of yourself, you wouldn't do 12 hours of that.
That's interesting. What are your thoughts on doing 8 hours in triage or doing 12 hours in triage?
I think that's highly person dependent. In general, I think 4 hours is about all the average emergency nurse really wants to do or should do. I always say my empathy level gets dangerously low after about 4 hours. There are nurses, though, who love it and can do it all the time. And so more power to them. I think for most of us who are classic emergency nurses, 4 hours can be a nice break. But after you hear, innumerable stories of things that should not have brought patients to the emergency department, you get a little less sympathetic. And 4 hours is about my limit on that one.
Yeah, that's a good point. I remember doing 12-hour shifts in the emergency department doing triage, and by about hour 8, I was like, if I hear one more person tell me how sick they are.
Yeah, I've actually never worked anywhere where we routinely did more than 4 hours. We always
really?
People in and out. Yeah. I guess I shouldn't say that. One place that I worked many years ago, we had a triage nurse. We had 8 hours, but they only did triage. They didn't work in the back. Which was good and bad. But yeah, no, I have recently had to have my thumbs reconstructed, and I've had a lot of hand pain. And a couple years ago, when it was really bad, before I got them fixed, I went into the charge nurse and said, now, I never asked for this, so please take this in the manner which it should be received. Can I please stay in triage for 8 hours? And he looked at me, his mouth sort of dropped. I said, my hands hurt so bad, I don't know if I can start IVs today.
Yeah.
So.
We at the facility that I grew up in, we would typically do, triage and trauma were 12-hour shifts. They were, you would go and you would do it for 12 hours, and you'd do a 12-hour shift. And, I would try to get people to swap out and be like, hey, those two particular areas were usually pretty easy to swap out. But everyone was like, nah, I don't want to do that. I don't want to go work trauma. I don't want to go work triage.
Right.
When really, I think they would find that the day goes by much better when you can just kind of break it up a little bit.
Like my favorite, if I've got to do 12, my favorite 12 would be to do 4 in triage, 4 in trauma, and 4 in the main ED.
That'd be a lot. That'd be a fun way to break it up. It'd be a fun way to break it up.
Yeah, because you can always see the end in sight of whatever you're doing.
Yeah. You're like, I just got 2 more hours. I'm good. 2 more hours, I get to go do something else.
Yep.
So, thank you again so much for your time, and I really appreciate you sharing your knowledge with my audience, and I look forward to seeing you when I see you.
Okay, take care. Have good holidays.
Man. All right. You too. Bye-bye.
Bye-bye.
Hey everybody, Kevin here. Just wanted to let you know, if you want the opportunity to see Jean in person, you have an opportunity coming up in March. On March 30th, the 21st annual SESS Southeastern Seaboard Conference is going to be happening in Myrtle Beach, South Carolina. Yours truly will be there, along with many of the guests that you've heard on this podcast. So if you're in the neighborhood, swing on by. I'd love to meet you. I'll put a link to the conference in the show notes below so you can take a listen. I'll be doing a little podcasting from the location, so hopefully I'll get a chance to meet you. See you there. Thanks for listening. Have a great shift.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.